I am Naomi Gerstel, a member of the Northampton Board and of the Speakers Committee. And first, I want to tell you a little bit about Northampton Neighbors, which is an organization that started in 2017 and now has about 900 members. And what it is an organization that tries to help people age in place by providing services and various kinds of social events, all kinds. And we were going around along full steam until the pandemic hit, and then we had to reimagine ourselves. And we did, and we still do some things like neighborhood circles, which each neighborhood has a circle where people meet and have exciting events, and of course the speaker series. The organization is free. It's free to anybody. Anybody over 55 can get services and of course offer volunteer help. We like to think of ourselves as an organization based on the important work of our volunteers who give so much. So now I just want to tell you a few things about the talk today, some logistics. You probably know that at the bottom of your screen is a little button with chat on it. And if you have a question, hit chat or click chat, write your question, and be sure to hit enter because otherwise your question won't appear. And it'd be probably best if you waited till after Jeff finishes to put in your question. But if you just can't wait, put it in and we'll come back to it after he finishes talking. The second thing is we have this marvelous transcription program called Otter, which is in the upper left-hand corner of your screen. And if you click on that, you can see a transcription of the talk captions as the speaker speaks. And it does a pretty good job. It's a great transcription program. The third thing is that everybody should be muted. So if you've unmuted yourself, please remute yourself. And the final thing is that this is going to be recorded, and Nina Kleinberg, our wonderful tech person, is going to post it on YouTube tomorrow, probably, once she does some editing. But we want to tell you it's being recorded because telling you and you're not leaving is you're giving us your assent to be recorded. So Jeff is going to talk for about 20 minutes, and that's going to be followed by a question and answer period. Let me just briefly introduce Jeff. So I am honored to introduce Jeff for his talk today. He's a local physician who graduated in 1983 from the University of Vermont College of Medicine. And then he did his residency close by at Bay State. He now provides palliative care and help with hospice, two types of care that he's going to distinguish and talk about today. He worked in Northampton at Cooley Dickinson for a couple of decades before he took off for what he thought might be a more attractive life in Seattle in its inpatient hospice unit. But of course, he discovered that he missed Northampton and his friends. And we are lucky and honored that he came back. He's now at Bay State, again in palliative care. And in addition to being a physician who offers medical help, he's a community educator par excellence. So some of you may have read his work in the Daily Hampshire Gazette or attended a very well-attended talk at the Forbes Library. I could go on, but I promised him I would keep it short. So without further ado, let me introduce Jeff Zesiger. You're on.
All right. Hello, everybody. Thank you for coming. You can see in the background is this great spiral staircase, and it was made by hand. And it's just a wonderful thing in our apartment here in Northampton as we move back to town from Seattle. And we just love to move back into it. It's a 100-year-old building, and you know, all of us are trying to get towards 100 years right now ourselves. So my talk today is very pertinent for anybody, but certainly people that are, you know, older. And I now can say to myself, yep, I'm one of the older people. And that's got good and bad, as we all know. Certainly the good is we're getting our injections, our vaccinations, and we'll have our immunity. So we'll be able to hug grandkids, and if you have them, or just your friends, which is a wonderful thing to do. So let's see, I wanted to share my slides here. The talk today came up with a catchy title of What the Heck is Palliative Care? Because I wanted to keep this a GP rating. And I think some of you have seen me talk around town. We had I think it was back in 2016, a great talk about Atul Gawande's book, Being Mortal. That was just a splendid time for the whole community here and in all the surrounding towns to get together through their libraries to ask questions, meet as groups. And I'm glad it happened then and not last year. It would have been hard to have the groups all online like this. But we've persevered. And at this point, I'd like to say palliative care. What the heck is that word? I struggled with it at first. Too many syllables, what does it mean? And I've often told people it means to surround, or in a general way, I like to think you're just giving people a hug, a professional hug to help them when they're having a difficult time in their health. So technically what we do is two things. We make sure somebody's as comfortable as possible. And the second thing is we want to make sure that they get what they're hoping to get, not what they maybe dreamed of, maybe not perfect, but what's reasonable, what's possible, how do you get there? And as all of us know, the medical system is large, complicated, and it's very easy to get lost in the system. Different people tell you different things. What do you believe? Who's pulling it all together? So palliative care often does a job of pulling the information together. At this point, I'm going to turn it back to Nina for just a sec to play a little video about what the heck is palliative care.
You are a bridge. It's true, or at least it's a good analogy. When you're healthy, when the bridge is sound, you can handle anything. Cars, trucks, trains, all the bumps of life, no problem. You are set. But if you're facing a serious health issue, something like kidney disease, lung disease, or cancer, the bridge starts to falter, cracks appear, and pretty soon it's hard to withstand all that traffic. Traffic that includes your own medical treatment. And that's where palliative care comes in. Palliative care is a specialized form of medical care, specifically designed for people with serious illnesses. Its main goal is to improve your quality of life by providing relief from the symptoms, pain, and stress that are an inevitable byproduct of both the disease and the medical intervention. In short, palliative care provides support for your bridge. And when a bridge is in trouble, there is nothing better. Now, palliative care, just like construction, is a team effort. It takes doctors, nurses, social workers, and other specialists, all working together with your physician to realize that extra layer, the layer that can make all the difference. It's a treatment method that makes sense at any stage of life and at any stage of an illness, because it's never too late to lessen the burden. So, next time someone you care about is facing a serious illness, remember this bridge analogy, and be sure to consider the enormous potential of palliative care.
So palliative care we'll get into questions pretty quickly today, because I always find that when we have talks together, community and myself, that your questions are the best. That's what's on your mind, and that's what I love to hear and be able to respond to. Some of the basic things we do, and as the video suggested, if you have a serious illness, all of a sudden everything gets complicated. It's good, therefore, to be prepared, because it could be next year, 5 years, next month, when you have to dig into your support structure and your planning to make sure you've got what you want. So I can't see everybody in an audience as well as I normally would, but usually when I ask people, how many people in the audience have a healthcare proxy, everybody who has put a hand up. And the second thing is, how many people in the audience have a MOLST form, the Medical Orders for Life-Sustaining Treatment? So these are two things that are super important, but they're just pieces of paper. What you want to make sure you've got is a family, a friend, somebody who understands what you really want, somebody who understands what you value in the world. And if you know what's important to you and share that with them, they'll know if you're in the middle of a medical situation, gee, would this treatment get my friend, my loved one, to do more of what they like to do? Or is this just going to be medicine doing what it's taught to do the best, make people live the longest, not keeping in mind how comfortable they are or how much they can really do? And many people who access palliative care, once they're comfortable, their biggest question to me is, how can I get back to doing X, Y, or Z? So whether it's golfing or gardening or just being comfortable enough to talk to your loved one on the phone, you'll have your answers for what's important for you. Those things change as you go through life. I already noticed that I used to like to drive cars on a racetrack. No interest right now. I love going out on my bicycle. I like going for walks. And certainly this past year, it's taught me that going out for a walk with a friend or a loved one is about the best thing there is, because no one's getting sick. You're getting healthier by doing it, and you get to share peaceful time. So make sure that you know what's important to you and you share it with your family and your friends. The way to do that is to choose a healthcare proxy. Most of you have already done that. But then I'd say, have you lately talked to your proxy about what's important to you? And with the time of COVID, more people actually have, and that's been good. But don't let the waning of COVID block you from doing more of that. Keep people up to date about what's important, particularly anytime there's a change in your health status. You'll want to give an update to somebody. You'll also want to share that with your doctor so they have an idea, your primary care doctor, or if you have a specialist that you follow mainly. That's the most important form, because if you're in the emergency room and you can't tell me what you want, your proxy is going to be called, and that person who has a brain and knows you is going to give some answers to the doctor on what to do. The second form is the MOLST form, and that's one that's bright pink in the state of Massachusetts. And it basically says things like, if my heart stopped, would I want to have resuscitation? If my breathing stopped or got so bad I couldn't sustain it, would I want to be on a breathing machine? And a lot of that's been tested in COVID also. That form is only a backstop, I tell people, because you and your healthcare proxy are the ones that are going to say, what are our options? What can we do? How hard is it to do this treatment? What's next? And then keep having an ongoing discussion. But if you weren't available, and in the time of COVID, somebody could have been sick, your healthcare proxy could be sick, and then who's speaking for you? You may have on your healthcare proxy form designated an alternate, and that would be good. They go to that. The doctors would, that is. But having a MOLST form, particularly just putting both these forms on your refrigerator in case in an emergency, the ambulance comes to your house to give you support or take you to the hospital. The third thing you see on the slide here is a personal directive or a living will. And I've underlined that as not legal in Massachusetts, but whenever I see one of these, I read it and make sure that I try to follow it as best I can. Pretty much, I would say most of the states in the US do not recognize living wills, but some of them do. So by all means, you can do one. They're online. There's many ways of doing it. And I have a slide at the end to say some ideas on where to go for filling that out. Here's a picture of a Massachusetts healthcare proxy. There's various versions of it. You'll basically see the Mass Medical Society did one, the Massachusetts Bar Association. But if you just went and put it in the browser and search for healthcare proxy Massachusetts, you would get something like this. You'll notice that you get to name one or two people as your proxies, and you sign it at the bottom, and 2 witnesses need to watch you sign it. To contrast that, our good old Molst form in Massachusetts, which, by the way, I might say is in the process of being reviewed, and it's probably going to change in the next few years. And we're working on an electronic version also. This says things like under A there, would you want cardiopulmonary resuscitation, CPR, and shocks to try to get your heart started again? Ventilation, like the breathing tube or a mask, transfer to the hospital. And some people, particularly people on hospice, say, I don't want to go back to that hospital. Thank you for what you've done before, but I'd like to just be comfortable at home. So here's the second page of a Molst form, and it lets you further delineate the things you would or wouldn't want and how long you might want it. Some people tell me, for instance, oh, I'd be on a ventilator, that'd be fine, but I wouldn't want to be on one for very long. And some people get stuck on a ventilator, and many people say, that's not what I meant. You know, give it a good try, but if it's not working, please let me go. And that's something that we would certainly honor and make sure you were comfortable if you got to that point. This, you can see, lists dialysis, artificial nutrition, like a feeding tube, and artificial hydration is IV fluid. There's one question that has come up several times that's very interesting. And I didn't have much of an answer, but the answer is starting to form in the press right now. What if they don't listen? So I've had people at prior talks say, I have my forms done, my proxy knows what I want, but I'm worried if I go in the hospital, they're going to do more than what I want. They're not going to stop when I want them to stop. And that could make you very afraid of even going to the hospital, and I understand, because you lose so much feeling of your own control when you're not in your own home. There's an example in the New York Times from January just this year where they list various court cases that have come up and are pending now, and some have even had settlements or payouts for people that got more care than they wanted. They were trying to tell the hospital or the doctor that they wanted to stop. No more antibiotics, or please stop the breathing machine. And my experience with other doctors is many don't understand that we really want to be in control. We want to be able to say, no, enough's enough. And at times, if you've been through an illness that's really wearing you down month after month, you're just weary and you don't really want that next test. Some people don't understand that, and they feel like the only reason I went to medical school is to save people. And saving means fixing, and fixing means lots more tests and treatments, which many people don't want. So I can see that, and I can honor people's wishes easily, but it's a complicated system in medicine. So I understand that you may come up against somebody who doesn't understand your wishes. That's when your healthcare proxy comes in handy, or your family, to back you up and say, really, this is what we mean. Please, this is what we'd like to do next. We want to avoid such and such. So you may want to refer to this article. It's on the last slide that it'll get to later, so you can look it up. And I think Nina was saying we could put it in the chat somehow also. So I'm going to stop right now because I can go in a million different directions, but I would just love to hear people's questions, either in the chat, as Nina and Naomi mentioned, you can type it in, or just ask the question and you'll be recognized.
Thanks for a terrific talk, and I can't wait to hear people's questions. This is such an important issue. We would clap, but it turns out clapping on Zoom doesn't work very well. So imagine that we're all clapping in response to a terrific talk. But before we turn to the questions, I have a few things I want to talk about. The first is that I wanted to introduce the next few speakers. The speaker series has a speaker every other Friday from 3 to 4. Everyone's welcome. When I say the speaker series selects those speakers, And we have lots of wonderful names. And as you know, just like today, we have lots of wonderful speakers. I wanted to introduce the Speakers Committee, who puts in a lot of hard work selecting and interacting with these speakers. They are Sarah Backrack, who I see is outside walking around. I don't know if she knows she's being introduced. Linda Desmond, who's just waved. Mark Harpel, who had his screen off before. Sarah Lennox. And unfortunately, a member just passed away, Zane Kotker, who was a wonderful member of our committee. And we miss her greatly. But another reason I didn't just want to talk about Zane, I wanted to say that we have two new members we're very excited about. One is Rachel Naismith, who had her second shot and isn't feeling so well. And the other is Jane Fleischman. So we very much look forward to them joining our committee. So now the next few speakers. On April 9th, we're going to have Howard Bryant from ESPN talking about the House Divided, Sports in a Polarized America. On April 23rd, we're going to have Jennifer Taub. Her name of her talk is Big Dirty Money, Making White Collar Criminals Pay. You might have read a review of her book recently in the New York Times. And finally, on May 7th, we're excited to have Jane Lerner and Michael Kane from the Movement Voter Project. And the title of their talk is Movement Voter Project, Grassroots Organizing and Electoral Power, which we're very much looking forward to. And finally, a little word from your sponsor, that is Northampton Neighbors. I know that this has been a very difficult time for many people. And so we understand if you can't contribute, but if you can, we're a completely volunteer organization, except for one wonderful administrator, Diane Porcella. And we survive by donations. We have a lot to pay for. So we would very much appreciate any donation you can make of any size. And all you have to do is go on northamptonneighbors.org and you'll see a donation button, and you can donate through PayPal, credit card, or you can send us a check. So now to the next important part, which is questions and answers. And the way this is going to work is you can put your questions in chat, and I'm going to moderate, and then Dr. Z is going to answer. So there are already some questions there, so let's begin. Let's start with Rachel's question, our new member of the Speakers Committee. I don't think you specifically mentioned pain meds. I hate pain, so I'd want as many pain meds as possible before I go. Who decides who's going to be done with what's going to be done with this in this regard?
Great question. And it's a charged question nowadays because we have so many people dying of overdoses, so much addiction, even from, and particularly from prescription pain medication use. My mom always told me, watch out for either side of the pendulum swing, try to stay somewhere in the middle. And I think medicine's trying to do that now. Enough pain medicines without causing problems with addiction, but don't be stingy so somebody's actually suffering. What I notice is that pain is a complex thing. It's whatever the sensation you're feeling, burning, deep pain, whatever, ripping, just people give all sorts of adjectives. That makes me nervous just to hear about it. And when I have pain, it makes me nervous. Everyone gets nervous with pain. And therefore, what we should do is say, yes, you should get as much pain medication as you need for your pain. If you're near the end of your life, I'm not worried about addiction. I'm just really worried that you're going to be comfortable enough to enjoy a meal or a walk or being with a friend or a family member. So yes, you should get enough. The thing we can't forget, though, is it's making you nervous. So if we just treat the pain, we may not get very good control. You may still be revved up and nervous. If we work on touch, back rubs, warm packs, hugs, anxiety medicines, all the kind of small or medical things that we can do to work on the anxiety, your pain also goes down. So we just want to use a little bit of several things and you get the best success. Who decides this? Well, it's really whoever your treating physician team is. And what I see in the hospital, I'm working at Bay State now, is that there are a lot of people, a lot of cooks in the kitchen. So there's a little negotiating that happens. There's delays also. Somebody agrees to doing something, and then it happens an hour later, and the pharmacy gets it an hour after, and the nurse gets it an hour after. So it can be very frustrating for somebody in pain to say, what's going on? You know, you wouldn't wait 3 hours for a meal if you went to the restaurant of your choice. You'd go to a new restaurant. But in the hospital, you're kind of stuck. So you need advocates. You need to be a nudge, a somewhat pleasant but insistent person saying, gee, my need is not met. I really need some pain medicine. And they'll ask you, well, what's your pain? Where is it? How much? And just give them a clear indication and then say, how long will it take this medicine to work? That's a good tip, because if the nurse says, oh, it'll take a half an hour, you can then ask the nurse, oh, I'd love to see you back in 45 minutes or an hour to talk about my pain. People are supposed to do that, but nothing like a pleasant, persistent person saying, I'd love to see you back and we can go over how it's going. If it's not going well enough, then you have to pleasantly say to the nurse, well, this isn't nearly enough. Would you please call the doctor again, or the nurse practitioner, PA? So it's a way of getting at it persistently. Don't just take their answer as the answer for you. Take it as a good starting point.
Thank you. The next question is from Catherine Baker, and she says, my estate planning lawyer and my primary care doc disagree about when a MULS form should be filled out and when it goes into effect. What's your recommendation on when a MULS form should be filled out?
So it'd be interesting to hear which one's which. My guess is going to be that your primary care doctor says you're not sick enough to fill out a MULS form. I've run into that quite a bit. However, the people that I talk to, primary care doctors, after a while of thinking about it, some have come back to me and said, well, you know, you're right. It wouldn't be a problem to have it a little bit early. In the past, it's been, and it still is, according to the regulatory authorities, something you do when you're having a serious illness, so you have an insight into what might happen, and it's the right time to say what treatments you might want. I don't think there's any problem at all, and it's certainly not illegal to fill one out earlier, because you have an idea what you might want if you had your breathing stop or your heart stop. You have experiences from your family, your friends, and you may know very clearly and not ever vary in the rest of your life about those decisions. So it's okay to fill one out early. You'll have to talk to your primary care doctor, because that's the person who will probably sign it. Unless you have a specialist, you could get them to sign it also. It can be signed by a nurse practitioner, a physician assistant also. And let's see. I think that's a good answer for that.
Okay. The next question is from Mark Raquel, and he asks, could you give a disguised example of how palliative care has not just made an individual comfortable, but enabled them to do as much of what they wanted to do as possible? What does it involve besides pain medication?
I can come up with a scenario very easily. If you, for instance, had somebody who had an illness involving their breathing, and there was pain involved. It could be a cancer, it could be blood clots in your lung. You're not comfortable. You can't do what you want to do. You can't go for a walk. You can't go to the grocery store like Nina said she is delighted to go to after 10 months. You'd be stuck sitting in a chair, kind of trying not to move. And that's not sufficient. A little bit of pain medicine, enough to back the pain from a 9 or a 10, which is sort of the maximum, down to something more manageable like 5 or 6, might be enough to get you up out of the chair. And then you start to make your own meal. You might go out, do a little grocery shopping. So that's how pain medicine could help. But there's other things. Some people say, I'm short of breath. Jeepers, you don't have oxygen. Maybe that would help. Let's try it. Maybe you have fluid on the lung. Why don't we help get it off? And then you have more lung to breathe with, and you can go out and go for a walk. So whether it's pain medicine or anxiety medicine, you're stuck in the house because you're so nervous, you're basically agoraphobic. You don't want to even leave. If you treat those things, you become more functional. And that's what everybody wants, to do the things that are important to them.
Okay, here's one from Nita Kleinberg. Is there a special palliative care unit at Bay State, or are the patients mixed in with the general medical population? Is the staff specially trained to deal with all the medical ethical issues related to palliative care?
That's a big cluster of questions. So there is no particular wing at Bay State or Cooley that has that. Where I went to Seattle, there was a hospice wing. And for people right at the end of life, they might go to the hospice wing. So if you, for example, were at Bay State, what you would do is talk to your doctor and say, I'm not comfortable. I think maybe palliative care could be of help. Could you please consult them? We get that on the list. We go out and see you and say, how can we help? And it may be that you're pretty comfortable, but you're not sure which way you want to go with your treatment. We would come and talk to you and your family and friends to come up with a good sort of a compromise. What's a good way to go forward? So, and I think there was a final part of that question. Could you say it again, Naomi?
Sure. Is the staff specially trained to deal with all the medical ethical issues related to palliative care?
So the answer is people have been exposed to these things, but I wouldn't say everybody's trained to do it. People know how to give a shot of medicine, a pill of medicine. Some people are just naturally less bothered by the hectic pace in a hospital, and they can reach out and just sit down with you for a minute and hold your hand. Even just a minute of that can make such a difference. Answering the call bell, that makes such a difference. So the basic things matter the most. And then things like ethical dilemmas do come up. And I met our ethicist when I came to work at Bay State, Peter DePergola, and he is fantastic. He has such a heart. He also knows what's legal, what's ethical, and how to move people through a system when it gets complicated and nobody's agreeing. So Bay State does have a really good way to deal with ethical dilemmas.
I see the next two questions, one from me and one from Lee Bailey, are almost identical. So let me read Lee's. Can you speak about the differences between palliative care and hospice care and the origins of both?
Well, that's a plant question. And I was supposed to basically get into that, and I totally forgot when we started the talk. But it's important. Palliative care and hospice get confused a lot. And in each country in the world, things are called different things. In the United States, we have a pretty clear differentiation between the two. If you were to go up to Canada, they're synonymous. And it just means if you have a serious illness, you need more support. You need maybe careful use of medications and trained people who know how to help you be comfortable and what your goals are. Here in the US, palliative care usually starts when somebody has a serious illness. You could have a serious illness start today, and it's something you deal with for the next 5 years. Palliative care could be involved with that on and off as you need it. Maybe you have a hospitalization next year. We could see you then. Maybe you wouldn't need to see us for another year or two. Oh, that now you do. It's also something linked more and more to visiting nurse associations. So Cooley, Bay State, Mercy, Holyoke, they're all working to have a palliative care branch to their visiting nurse service. So that would give you support at home for weeks, months, maybe periodically through a long illness. Hospice, on the other hand, tends to be something for people who are in the last 6 months of life. And that's only because there was a study done about 40 years ago, 50 years ago now, that said Medicare would pay less money and people would be more comfortable and happier if they had hospice type of support. So Medicare was, looking for helping us, but also how do we save money and not overspend on things? Therefore, hospice was born. It came from Dame Cicely Saunders from England. It's all over the world. It's in almost all communities in the US now. And it was the first thing that came here back in the 80s. Palliative care grew up out of that. And palliative care said, why do we have to wait until we're in the last few months of life, last weeks even of life, to get specialized care for our comfort? So it was born, it's slowly grown. The people that really started it here are now, interestingly, in their 70s and retiring, speaking still, and very, very vociferously to make sure we get what we need here. So palliative care tends to work also on function. People who have serious illness, I mentioned, want to be as functional as possible. People in hospice usually say, I don't really want it so much as I used to. I just want to be comfortable. I want to be home. I don't want to go back to the hospital. So those are the main differences in hospice and palliative care. Insurance payment, some people will have a Medicare or private insurance. It usually pays for either one. But the big thing I notice is when somebody's near the end of life, hospice is really the best thing. Palliative care is good, but hospice is available 24 hours a day. If it's 2 a.m. and you have a problem, there's somebody on the other line, and that really helps.
Deborah asks, can you say more about how you address attitude or emotional issues for those who are seriously ill?
Well, that's something that that you can sum that up in one short sentence. Listen more. So what I've noticed, and studies have said also, is that medicine feels like it's always in a rush. People come into your room and say, okay, how are you doing today? How's your pain? How's your breathing? Oh, that's good. I'll see you later. And then you go write your note. Well, if you have a lot to do, I see why people do it. That's why I love palliative care, because I get to go in and say, tell me what's been going on. Give me your story. And then people tell me what's important to them. I piece together what's not working and start to say, I think we can help you. The next thing we do is, if somebody's uncomfortable, if you can get them comfortable in the next few hours, all of a sudden they're going to trust you. They'll say, well, you can work for me in something as important as that. Nobody else has gotten me comfortable even a little bit. Now we can talk some more about what's important to me. So if you listen a lot, if you really hear what somebody wants, and then also kind of make sure that you've talked to their family and friends, because they may have a family that says, oh, dad wants this, but dad tells me, no, I want the opposite. And I just had a case like that in the last week at Bay State, where this 90-some-year-old person just wanted to go home, wanted to look out the back windows and see their yard. And the family said, gee, I really think they waver back and forth. Maybe we should do more. But in the end, the answer was lots of communication later. Let's just get home. Let's enjoy the spring as the flowers come up.
Okay, so from David to everyone, what is the relationship between palliative care, hospice care, and end-of-life assistance.
So end-of-life assistance, I'm wondering exactly what, David, you mean by that. If you can throw that in the chat, that would be good. But hospice and palliative care, for example, at Cooley, when I was doing palliative care, I was also doing hospice. It was very convenient. If I got to know a person one way or the other, it didn't matter. I just figured out what they needed and let's get the services. At Bay State, it's a little different because it's bigger, more people involved. There's a big palliative care team. So I might meet somebody, and yesterday, for instance, I was talking with a gentleman and he needed a certain kind of treatment that wasn't usually given on hospice. It was a little more active treatment, but it made a lot of sense. And so I reached out to the hospice director and said, gee, is there any reason we couldn't do such and such? And the answer was, well, I don't think so. Let me check. So that's how we relate, by just reaching out as colleagues one to the other. And as we get to know each other more, we can kind of anticipate who to ask, how to ask them, and get the things you really want. As for the end-of-life assistance, let's see.
He just put up another chat. You want to read it? Or you want me to read it?
I think I see it now. End-of-life planning. Exactly. I understand now. The way that we all reach end of life is amazingly the same, unless you have a sudden death. Most of us have a certain amount of energy, and I think of the Energizer Bunny. We keep going, and we surprise ourselves and others by what we can put up with and keep working to do. But eventually your energy's, used up. And at that point, you reach the end of your life. There are people that say, I don't want to wait until I just naturally get to that. People on the other side of the spectrum say, I want to extend my life no matter what. I'm willing to put in a lot of effort, put up with a lot of grief and discomfort just to live longer. And they may have a particular reason, like their son may be graduating from high school in a few months, and they just really want to be there for it. So it all depends what you want. Palliative care is there to try to help you get there. The thrust of this end-of-life planning that you're mentioning is, what if you don't want to wait for that? So I've had experience, and people have heard me talk about some of the wonderful people I've met who have said just that. I'm ready to finish with this life. It's been a great life. I'm not depressed. I'm not anxious. I'm not panicking. I'm just ready to say that's enough. And there are organizations around the country, you can get them online, that say, we're here to help you end your life. And there are various ways of working to do that. The simplest way that I know, and I've experienced with several patients, is let's stop eating and drinking. And if you stop drinking, you die within 2 weeks, roughly. If you drink a little bit, you might live a little bit longer. So you would have to put up with a very, very dry mouth, but your body does not go on and on if it doesn't have fluid. So I keep in the back of my mind, if I ever needed to, I know I don't feel trapped. I know I would just say, I'll put up with a dry mouth. And I think that's called voluntarily stopping eating and drinking, VSED. And VSED is something we've had some people in town here who were followed by the newspaper, for instance, 6 or so years ago. And some people don't understand that and feel it's not a morally correct thing to do, but most people say, yeah, that's your control. Whereas taking pills or trying any other way of dying quicker or sooner, that's more questionable in a lot of people's minds. I think there's going to be a time in the next few years where medical assisted dying or medical aid in dying will become legal in the state of Massachusetts. It was about 6 years ago, maybe a little more, that there was a referendum and it didn't pass. But I think that's going to come through the legislature, and there are more and more people interested in it.
Okay, this is from Trish Collard. I think that's how you pronounce her last name. Does Cooley Dick have an ethics person and staff for palliative care?
What they do is not just have it in palliative care, but they have an ethics committee, and that's how I got introduced to ethics. And it's usually the absolute hardest, most challenging situations that require ethics, because everybody's feeling the distress of somebody suffering, and staff can really go home and take it with them and not sleep and end up crying and be very frustrated. So Cooley's answer to that is to have an ethics committee. That committee, if you were a patient at Cooley, you could say, I don't feel I'm getting what I really want. There's disagreement here in the hospital about what to do for me. Could you please call an ethics consult? And those consults bring in people from the community, people working in the hospital in many different realms, doctors, nurses, social workers, spiritual people, and they look at a conundrum like that from a different point of view. And in doing so, people understand what your wishes are much better. And usually that resolves the problem.
A question from Roslyn. At this point in time, does Bayside have practitioners who come into the home to help people who are dealing with chronic progressive illness, but not homebound?
So there's good old medicine splits things into various components. And when I started medicine, I was in private practice. So if somebody needed something, I would just go to their house. I might have visiting nurse go to their house. I would see them in the hospital. I would round on them in the hospital, admit them at, odd hours. And medicine's been split up in the last 20 years. So I've seen it become more special people to do this, that, and the other. There's good in that, but there's fragmentation, lack of continuity of care. So people that would go into your home tend to be people, maybe your primary care doctor, sometimes, but less likely, I think, your specialist. Visiting nurse would go into your home, and they would have home health aides, nurses, social workers, for instance, physical therapy, occupational therapy. So those are the people who can go in when you have a chronic illness that usually you have a hospitalization, you're much sicker than usual, and then you go home. At that point, you get those people in to help you out. If you just have a chronic illness and it's the same really challenging situation day by day by day, we don't have a whole lot of options. The only option I'm aware of is something, the PACE program started it, and that's, I'm forgetting what the acronym stands for, but it's continuing care for people with intense illness, basically. And there are some down in the Springfield area that also come out to your home and give more services. Those two programs usually are for people that have Medicare and Medicaid insurance, or Mass Health in this state. If you have both of those insurances and you have a lot of medical problems, you're usually offered the ability to use standard insurance or sign up for one of these all-inclusive plans. They're not HMOs. They're just special programs for Medicare and Medicaid when you have both. So that's sort of the scenario of what's out there to help you. The thing to do is ask your primary care doctor and say, I have these issues. What else can you bring to bear to make my life, more pleasant and help my function?
Okay, now we have another question from Nina Kleinberg. And she says, does Massachusetts law protect you from being charged with over prescribing opiates for palliative care? Are there any legal protections for any part of your management of palliative care?
That's a good question. There is special dispensation, so to speak. In the state of Massachusetts, if you're a palliative care or hospice provider, they rarely give you any grief about the prescriptions that you're writing. If you're a regular practitioner of any other sort, there's a list of how many prescriptions you give, how much are you giving out, and the people that give out lots and lots are usually investigated to make sure that they're doing it legitimately, that they're making good notes for each person, for each problem, what's the plan, what's the follow-up, and they're not just seeing people for 2 minutes and handing them a prescription. Palliative care, so far I haven't heard of anybody in palliative care having a problem prescribing the amount of medicine needed for somebody's comfort. And there are times that it's 100, 200 times what somebody else might need for pain relief. And you almost can't believe somebody could be walking and talking with that amount of medicine. But your body is amazing in how it can break down medicines and adjust to things. Legal protections, I think we just don't get hassled. Maybe we've behaved well so far. Let's knock on wood that we don't cause a problem for ourselves.
So we have one more question, which is a good question to end with, because we only have time for 1 minute more. So look to the future. It's from Sarah Lennox, and it says, how fast are notions of palliative care changing? Do you think what you are telling us today will still be true, say, 10 years from now?
Lovely question. That's terrific. Future thinking. I think palliative care has been around long enough that we've seen where it's kind of settling in. I think what you're going to see is that palliative care experts are going to say, there's not enough of us. We can't get to everybody. How do we either train more people, and we can do some of that, but how do we train everybody in medicine, going through medical school, nursing school, social work school, to know primary palliative care, as they call it. So know the basics. If you know how to treat somebody's pain and quickly can get them more comfortable, you don't need me. You can get them more comfortable. If it's a more complicated situation, bring them to my attention and I'd be glad to help. So I think in 10 years, palliative care will be more easily found in all communities, just like it took hospice a couple decades to get that recognition. And I've already seen a major change in just the 15 or so years I've been doing it. So we'll be around. I think we'll be just around a little bit more.
Okay, thank
I
you.
have a couple of questions.
Oh, okay.
Okay, I can't type
Okay.
at the moment. I have a molest form hanging on my refrigerator door, and I have a proxy, healthcare proxy. If it comes to a difference of care, who wins out?
Between the two forms, you mean?
No, the healthcare proxy, physically,
Okay.
a person. Who wins out?
The proxy wins because they have a brain. So a piece of paper is a static thing that you fill out one day. You might change your mind and feel differently the next day. You could fill out another MOLST form and write void on the last one. You could do that 100 times. We just have trouble following it. But a healthcare proxy, in the thick of the moment, can make a decision, can say, well, the MOLST form says I wouldn't want to have my heart shocked, for instance. But the doctor in the emergency room may tell the healthcare proxy, this person accidentally took too much of this medicine. That's why their heart's about to stop. the medicine will be out of their system in 3 hours, by all means, give them a shock. And they may get mad at me later, but I'm gonna stick up for them because their quality of life has been good, and it shouldn't end just because they made a mistake with the medicine.
Okay, thank you. And I have another question. Are you familiar with 5 wishes?
I am, and that was my final slide. I'll say I reviewed 5 wishes because I was always a big proponent of it. It just made sense to me. But when I reviewed it, it's getting dated and it hasn't been fixed enough. So I found some errors in the logic as you make decisions. And the language in it can be off-putting in some spots. So it's still a very good thing if you've done that. Don't feel bad. I think there are better ways to do it now, and honoring choices, I think, is a better way to do it. So at my last slide, I'll show you as we finish, honoring choices.
Thank you very much.
You're welcome. Glad you spoke up.
Yeah, but people can't type. Please do speak up. Anybody else? I hear somebody speaking, but they're muted, I think. So I think it's 4 o'clock. We're ready for the last slide.
All right.
Well, before you show us the last slide, thank you so much. This was fabulous.
Oh, you're welcome.
I wish we could clap better.
You just did. My heart sails. Here we go. So honoring choices, that's the first one. You don't have to even have the link. Just put that into your browser and you'll find it's very logical and smooth. General palliative care information is the second one. And the third one was the New York Times article I mentioned earlier about if doctors aren't listening to your wishes and they're trying to keep treating you, they need to be reminded that it's legal to follow your wishes. And if they don't, there are lawyers that are starting to pick up on this and say, well, let's all be honest with each other and follow our wishes.
Okay, we're going to end the meeting now. This will all be visible, I think, on YouTube probably tomorrow. So again, thank you, and I hope to see you in 2 weeks for our next speaker. Bye, everybody.
Thanks all. Thanks for your questions.